everybody. Thank you for coming. Doors are closing. Take a deep breath. I'm trying to settle in because what a day, what a day. Yeah, have a seat. And I mean, you guys, there's chairs. You don't have to stand in the back. You want to sit down? Those of you who are standing, I mean, hey, it's an hour. Quick raise of hands. How many of you are Love.Life members? Woo woo. Hi. It's normally Michael does an introduction, but he isn't here. So we're gonna kind of forgo that, but I will tell you about the setup. I'm gonna talk today about hormone replacement therapy for about 30 minutes or so. And then of course we're gonna stop the recording and make sure there's opportunity for everybody to ask questions. At the end, for those of you who are not Love.Life members, if you do want a tour, we will arrange that as well. Brian is in the back, so we'll make sure that those of you who are interested in taking a look around the entire facility, that you have the opportunity to do so to learn a little bit more about what we're offering. I am Dr. Jaclyn. I'm one of the lead physicians here. We've got Dr. Anna in the back, and together we're the lead physicians at Love.Life. And this is number 5 in the longevity series. And I think there's a couple people who may have been to all 5, which is quite impressive. The topics that we recently chose for this series were very particular because they were kind of based off of a recent longevity conference. And I wanted to pick what I thought was going to be the most impactful. So we started out with basic things. We started to learn about mitochondria. And then we talked about the hallmarks of aging. Then we talked about women's health, just generally speaking. And then we went into menopause 3.0 and medicine 3.0 to talk more about what this looks like in people. And here we are at Hormone Replacement Therapy Demystified. I will tell you that out of all of these 8 lectures in the series, this is probably the one that I felt the most scared to do. And I think it's because it's such a hot topic and such a controversial topic that a lot of people are scared to talk about. But all the more reason when you're scared to do something, that's exactly why you need to do it, and so that other people can learn. And again, yeah, it's kind of a fun topic for me, and I do have a personal story around it, so I'm always happy to share. Disclaimer, for all of these presentations, remember this is information only. For some of you, maybe I am your doctor, and we have different conversations during our visits. But for those of you who aren't members at Love.Life, this is really just information. And you can take this information back to your doctors, or you can fire your doctor and find a new one. There's options for that. But it's an opportunity for you to just hear a point of view, an unfiltered point of view. So I don't know how many of you are new. This is the very first time, but I mentioned earlier, I'm one of the lead doctors here. I practice functional and integrative medicine. I'm board certified as a family doctor and continue to maintain that. And I specialize in hormone optimization really because no matter who you are, male or female, all ages, we're all going through hormonal things. And at different stages of your life, there's always a learning to be had when it comes to the different phases when it comes to hormone health. So that was an important thing for me. And last but certainly not least, I am a young breast cancer survivor from my early 30s. And that really changed the way that I think about medicine. It changed the way that I thought about my patient care, about what I needed to do for my own body. And really the whole trajectory of my career was kind of a turning point was the breast cancer diagnosis. So that's a little bit about me. So hormone replacement therapy, what is it exactly? Has everyone here heard of hormone replacement therapy? Yeah, lots of heads nodding. And this is just a basic slide that gives you some information about why and what people are doing. It's a treatment, and the whole point is to restore hormones in your body when the natural levels decline due to aging. So mainly it's due to aging, but there are so many people that are on hormone replacement therapy for lots and lots of other reasons, of which we're going to get into. Whenever you see the terms HRT, it's typically talking about estrogen, progesterone, and testosterone, so keep that in mind. And of course, there's other ways that we use hormones, like think of people who are on thyroid medication. They're also trying to support the hormones in a different way. But for the purpose of today's conversation, we're really focused in on hormone replacement therapy, referring to these particular hormones: estrogen, progesterone, and testosterone. And a really quick one-liner about what kind of symptoms people try to manage when they're on these kinds of medications: decreased libido, fatigue, mood changes, bone density, muscle mass reduction. This is just a very short list, and I'm going to show you a lot more about what these things can help support. Another thing for this summary slide, it talks about the different forms: pills, patches, gels, creams, injections. There are lots of different ways that people are getting these hormones into their bodies. And ultimately, this is the goal: help restore balance, improve quality of life, and also improve your health. Next thing, estrogen, progesterone, and testosterone. These are the main types. I mentioned that again earlier, but it's so important that you realize there are also different kinds of estrogen in your body. Progestin is different than progesterone, and there are certain studies where these combinations of estrogen and progestin were used in some of the studies that talk about hormone replacement, and then others where it was progesterone. So these are two different things, but they all are meant to support the body when it comes to progesterone. And then we also have testosterone, which is the hot topic for both men and women. I mentioned various ages because not everybody who is going through menopause or perimenopause is a candidate for hormone replacement therapy. I think that there's also people that are on certain types that have certain conditions, certain gynecologic conditions that are also reasons for them to be on hormone replacement. You'll also find that even in the world of fertility, when people are trying to get pregnant, sometimes they're even put on some of these medications as part of their protocols to help support that. In women, now we're just talking about without hormone replacement therapy. Logically speaking, the time that people consider replacing hormones with HRT is usually perimenopause to menopause. So women can actually spend around a third to half of their lives dealing with a decline in key hormones like the estrogen, progesterone, and testosterone. And that's just doing the math when you think about when women are going through perimenopause and menopause, that maybe a third or half of their life they might be dealing with some of the symptoms that happen. The next is the timing, perimenopause, menopause. We usually think of the average age of menopause roughly around 50 to 51. We now know that there are so many women that are struggling even in perimenopause in their 40s. And I think the recent study that was cited on the Today Show earlier today talks about how women even in their 30s, upwards of 35, are really starting to experience some of these symptoms. And sometimes their doctors aren't recognizing it as part of a picture of perimenopause. We know that hormone replacement therapy can help alleviate some of these symptoms, and that's why people seek out this kind of treatment. But remember that it's only one tool in the toolbox of many tools, and we always have to keep that in the back of our head, that when you're looking or thinking about hormone replacement, there are other tools that we can utilize, and this isn't just a one and done, end all be all. In men, as men age, testosterone levels naturally decline, and you can start to see this in 30s and 40s. I would argue that this is actually more like even early and mid 30s, that some guys will already start to see this. Look at the symptoms: libido, fatigue, muscle loss, and mood changes. And you can see, like I mentioned, it is one tool that can help support men. So bottom line, male or female, we're all going through these hormonal changes, right? It's not just women going through menopause, it's men also decreasing in some hormones as well. When you look at this slide, it's not just men or women. You can see a lot of these things in men, mild to moderate erectile dysfunction being one, and then muscle loss. Over on this side, can women also have muscle loss? Yes. Do we know that if people have inflammatory joints, that some women do respond really well when they're having joint pain or even shoulder issues like frozen shoulder, and they respond really well to HRT. And then you see some things in the middle: mood swings, depression, headaches, night sweats, insomnia, weight gain, bone loss, lots of reasons. Let's keep that in mind, that it's not just about men and women, it's that we're all and could be experiencing a lot of these. I put this picture up because I want you to see the difference in what happens with men when it comes to testosterone specifically. And you can see here in the 20s, look at how high it is. And as the age happens in the 40s, 50s, 60s, and 70s, everything starts to dip down. So we really start to see that decline in the 30s for men. And you see the difference here in women. It's a different pathway. You see here that for testosterone, it starts to reach a bit more of a peak in this particular decade between 30s and 40s. And then again, once we hit this window, also starts to decline. Let's also keep in mind that this isn't the only hormone that declines as we age. We learned last week in Menopause 3.0 that progesterone in women is also declining here. We know that blood sugar dysregulation is becoming problematic, that our immune system is also a bit more vulnerable. So there are also other things that are happening as we age, and it also shows a little bit more of this kind of a picture. I pulled this from the last because I think it's important to acknowledge that when you're looking at women in particular, there are changes that they see physiologically that are different from men. And especially in perimenopause, this no man's land for how estrogen is doing this crazy dance, again, can happen for women anywhere in their 30s, 40s, or even low 50s. At the end of the day, just like the last diagram, you see the hormones all decline. This is not an exhaustive list, but perimenopause, look at the symptoms. This is, I think what they mentioned today was about 30 plus symptoms, but I would argue there are more. And look at how many women are going to experience this, right? 75% of women will experience symptoms between perimenopause and menopause. I like this slide because seemingly you would look at it and think that some of these symptoms are completely unrelated to each other. Somebody might go to see a doctor because they're having anxiety, depression, irritability. Somebody might be seeing a doctor because they're having digestive issues, or over there on the left, decreased libido, vaginal dryness, or they just can't sleep. But when you look at this list, some people have all of that, and their doctor might not acknowledge that it's part of perimenopause and what they're experiencing, and they might just be treating one little thing with one medication and calling it a day. So what can affect hormone levels? This is also not an exhaustive list. And you do see aging at the top because we talked about how naturally there is a decline in those hormones. But chronic stress is a big one. We know that slowed down metabolism and weight changes affect the hormones. The way that your brain is signaling down to the rest of your body, including the endocrine glands, is mentioned there. We know that the thyroid is almost like this satellite, like a radar beam to different areas of the body. If the thyroid doesn't work well, patients also have irregular cycles. So we know that there is a tie between the thyroid and how the ovaries work. You see blood pressure and cardiovascular things there mentioned, like cholesterol issues. And then poor metabolic health and blood sugar dysregulation. Certain conditions can affect it. Infections can also affect it. And then we talk about sleep and light signals and sedentary lifestyle. And then our last in the series, we're going to talk a lot about gut health. The reason why this one to me is probably one of the most important ones is because we take for granted how important sleep is. And when our body is truly aligned from a circadian standpoint, the way that it works in terms of hormones and how hormones are created is that there's a feedback loop. The brain is signaling down these areas, and these areas are then signaling to the brain. But what signals the brain to begin with? And it's really about light and your body's circadian rhythm and how well you're sleeping, because that's probably one of the most important signals that starts the engine and revs up things to start your day is how well you sleep. So we're going to go into the science of sleep in an upcoming lecture so that there's more information there. The last thing I'd say is this inflammation is probably a big one that is underestimated, because right now, all of us are exposed to so many different toxins that the toxic burden on our body and the inflammation that that creates is huge. So there are certain aspects of lifestyle, there are certain endocrine disruptors and chemicals that are in everything that we're putting on or in our bodies that we also have to acknowledge can also play a role here. And so where do they get hormones or how are they used? They're typically managed by doctors and they are available by prescription. Some compounding pharmacies and some pharmacies do show people how to put them on. And as I mentioned, there's oral pills, there's patches, there's gels, there's injections. I typically like the bioidentical hormones because they are literally plant-based hormones that are chemically identical to the body's natural hormone production. So I typically use these kinds of hormones, although there are synthetic hormones that are also available. And you can see there's just a few key distinct differences between the two of them. The body does have to convert this to a usable active form, whereas the bioidenticals are, some of them are FDA approved, some of them are not. And they also have this option of customization, where the synthetic preparations oftentimes, they only come in certain doses of certain types, and you don't have a lot of leg room to be able to customize. How people put them on and where, you can see that the topical creams, normally they're applied here, they're applied to the groin area. Some people put them behind the legs and some thin areas there. The inner thighs are probably the more common area that I like to recommend them. Patches usually are here in the patch area or even in the low back. And there are pellets, hormone pellets, that are inserted under the skin. Injectables for guys, you'll see different preparations of testosterone injected into the muscle or even subcutaneously just under the skin. So not quite the muscle, but maybe even in this area. And see, there's so many different varieties. So it's hard to even know which one you should be taking or why or how. And that's why it's so important to talk to your doctor and have an honest conversation about it. The next thing, when do people start taking hormones? For women, you see perimenopause mentioned there. And when you go back to the slide thinking about how 75% of women are going to experience one of those multitudes of symptoms, if women are going to start it, typically there are certain preparations that you would want to start in perimenopause versus just starting in menopause. But what I'd say is a lot of women and men are coming to this whenever they get to this at this stage in their lives. I'll have some patients that never even heard of this treatment as an option, and maybe they're coming to me over 50, and then, or even over 60. And then maybe you're gonna have some women who are in their 30s who are already starting to recognize that some of these symptoms could be due to hormonal imbalances in estrogen, progesterone, and testosterone. So it's never a true finite recommendation on exact timing of when to start. It's always a thoughtful conversation. You can see here for men, typically around ages 40 to 60. I would argue that there are some men who are really struggling with hypogonadism. Their body is producing lower amounts of testosterone, and as we're figuring out why, there are some that might be candidates for replacing at an earlier age. But again, it's always a very thoughtful conversation, because what you'll notice in guys is there are some nuances with testosterone replacement, such as shrinking of the genitals. And that's something that we think about. We're also thinking about how these hormones are getting metabolized in the body. So it's not black and white. You know, typically it requires a lot more education around that. I thought this article was interesting from March of 2020. And the heading, should we be prescribing testosterone to perimenopausal and menopausal women? A guide to prescribing it for women in primary care. And I have the printout here in case anybody is interested. This one's only a few pages, but I like the fact that we're even acknowledging that even though testosterone is not FDA approved for women, that it has a place in the conversation and that there are women who are also utilizing testosterone. Why would that be important? Up until this point, a lot of the conversation was around estrogen and progesterone. But why wouldn't we or couldn't we replace testosterone as well? A lot of times people may come to me and they may have only been put on estrogen or maybe just progesterone or just the two, but they might still be experiencing some symptoms and maybe they want to use it for libido. Maybe they're thinking about energy. Maybe they're thinking about the loss of muscle mass and how important that could be. So it does require a conversation. But sometimes when I ask people and I say, oh, I noticed that you're not on testosterone replacement. Have you had a conversation about it with your doctor? No, never mentioned it. Still think it deserves a place. There should be a conversation about it. The next one is also an interesting one too. This one is a lot longer. I think this one's probably from the American Heart Association, which is interesting to me. And it has about 233 references. Menopause transition and cardiovascular disease risk, implications for timing of early prevention. In the last lecture, and if you go home with anything, remember that hormones are important for bones, brain, and heart. Bones, brain, and heart. You'll see that it's important for a lot of other things, but bones, brain, and heart always sticks out in my mind for lots of different reasons. Here we're talking about cardiovascular disease prevention, and in the American Heart Association, it is showing us, and it does have a lot of info in terms of lifestyle optimization and things that can be done, but it's basically mentioning that the original guidelines for cardiovascular disease prevention that came out in the year, I think 2011, didn't include any thought or conversation about what menopause does to women. That sucks, the fact that it wasn't even acknowledged. And when you look through the literature and you look at this one in particular, it actually goes deep and it talks about how there is a place for hormone replacement. There's a place for lifestyle optimization, and we do see distinct changes in men and women, especially in menopause, that do affect us from a cardiovascular standpoint. The fact that that wasn't acknowledged in 2011, and now they're going back to say, hey, there's an important discussion to be had, I'm glad that we're coming to terms with being honest, because it's important for us to think about that. Symptoms that it can help relieve. Again, not an exhaustive list. And you see that there's female symptoms or male symptoms. But what I'd say is that nothing is perfect, including hormone replacement as a tool. There's always opportunity for us to support our bodies in lots of different ways. But this is just an example of some of the symptoms that patients can benefit from. I do see this a lot. We do DEXA scans here at Love.Life, and a lot of people, both men and women, interestingly enough, under the ages of 65, are really struggling with bone density, and they're starting to show signs of fracture risk. They're diagnosed with osteopenia. And as we continue to lose bone, hormone replacement therapy, estrogen therapy, is an actual treatment that is actually at the top of the list that can support people. And so here you can see I listed that. Helps maintain bone density and reduces the risk of osteoporosis. Relieves menopausal symptoms. We know that although there are so many treatments for menopause support, I think in the last lecture I gave you all a sneak peek of two very important slides on the natural compounds and even food-based compounds that help support vasomotor symptoms like the hot flashes. But here you can see that relieves menopausal symptoms, alleviates hot flashes. Out of all of the treatments out there that can help women with hot flashes, hormone replacement therapy is probably at the top of that list. Can we support it in other ways? Sure, we can. But can a little bit of estrogen help support women with that? Yes. And when you look at this list, improves sleep quality, helps to support your energy, enhances mood, there's a recipe for what kind of hormones are going to be beneficial for you. And that's why it's always important to talk to a doctor about it. It's not like you should just be on one or you can only be on another. It's always a conversation about what and why. This wouldn't be right to not talk about benefits and risks, but I'd argue that the risks, they all have this little asterisk here, because we have to take it into consideration, right? Just like any medication that you get, or even birth control, I don't know if you've ever looked at the packet on birth control, but the risk list is 100 things long. And a lot of women just kind of toss that little packet, but when you actually look at it, there's some important things to be said there. When doctors are prescribing these kinds of medications, we do thorough evaluations to understand truly what people's risk is. And when you look at the risk categories here, it's not just a blanket statement to say that all hormones are going to cause this. There are certain kinds of hormones in the studies that did create these kinds of risks. Sometimes it was certain preparations of estrogen, or it was not progesterone, it was progestin. And so I think that we have to take that into consideration, that the preparations, the type, who's using them, what's going on in their lifestyle, what other medical conditions they had going on. There's lots of factors that can contribute to it, and it's not just a blanket statement of what's black and white. So at Love.Life, we practice a very individualized approach, and we call that N=1. We call it Medicine 3.0 because there's an opportunity for us to be very much preventative. And when you look at the intake process for people when we're treating them for hormonal issues, we do a thorough history before the first visit in the form of a symptom questionnaire that goes through medical history from birth onward. And then we also spend an hour listening to you and listening to your story. So even before we're diving deeper into what a treatment plan could look like, yes, of course, diagnostic testing might need to be had. Maybe there's screening tests that you haven't done, if you haven't done your mammogram or your pap smear, or maybe you hadn't done your colonoscopy, et cetera. So there's pretty much levels to taking a look at somebody's health holistically. We take the history and we date it all the way back from when you were born, but then we're also looking at everything that happened along the way. Then we are also doing diagnostic testing. The comprehensive labs includes full hormone assessments because we find value in looking at hormones as a symphony and not just looking at one hormone because hormones don't act in isolation. Over here, the personalized treatment plans, you can see all of the things that are pretty much involved for us. And it's not like we can't prescribe medications if I felt that a synthetic hormone is what somebody needed. But 9 times out of 10, I stick to the world of bioidentical hormones because it is chemically identical to what your body recognizes. And I also find that those custom preparations work really well. Interesting hormone tests and why they can be helpful. This also is very specific to hormones. You can see that we can find out about what people's serum levels are for hormones over on the blood tests. We also like to look at how your body is metabolizing said hormones, which is why we also include urine tests. There is also saliva tests that show us cortisol, because right now that's what we got. It's the most accurate way for us to look at somebody's circadian rhythm and look at what their cortisol pathway is throughout the day. So we take a look at that. And then, yeah, there are some at-home tests that are also helpful for us as well, like taking a look at the gut microbiome. Some people are interested in that data and they want to see what that looks like because of how helpful it could be. So I would argue that when people think about hormone replacement therapy, it's just one of many other tools. And when somebody comes to see us at Love.Life, we don't start there. You're not going to automatically start with putting somebody on hormones. It's really part of this thoughtful conversation. But at least we get to have the conversation. A lot of people, including some that attended last week's Menopause 3.0, mentioned that they weren't even allowed to have these kinds of conversations with their doctor, that they may have been on or wanted to be on hormones for the last 5-6 years, and their doctors may have shut them down. You hear that often, that doctors might not even be open to having that conversation. So this is where I would put hormones. I'd put it on this list of what else we can do. It's certainly one tool in the toolbox. For some, it's a really important tool that's been missing because maybe they've been working on everything else. But there's also those nuances. There are certain tests that we have to do. There's certain ways to screen. Should people be getting screening tests done? Why and when? Mammograms, pap smears, what place do they have? All conversation pieces, right, that people can have with their doctor. So I would still put hormones here. What I'd say is I've been practicing in my concierge practice back in Miami. I was seeing a lot of people for hormone replacement, and everybody loved the way that they felt. So from a symptom standpoint, this is not about people who are in menopause and andropause and jumping up the levels to their extremes and bringing back period cycles in women in their 60s. That's not what this is about. This is about alleviating symptoms, number one, and then also doing what I said about bones, brain, and heart, right? Protecting the bones from osteoporosis, supporting brain health so we have good memory and we're not concerned about dementia, and also supporting cardiovascular health. So there are those main reasons, but of course we see that there's so many other symptoms that are relieved, including the hot flashes, for patients who are good candidates for this. Now, this top 5 myths about hormone replacement therapy came from a lecture that Dr. Fitzgerald and Dr. Smeaton did. Dr. Smeaton is from Dutch. Dr. Cara Fitzgerald has her own practice. But I like it because these are really common myths that you hear about. Myth number 1, Here we're talking specifically about menopausal hormone replacement therapy. Must it be stopped at age 60? And for those of you who were here last week, I brought on Dr. Christy Evans, and we talked exactly about that. We talked about how even though you commonly see that hormones need to be stopped, the truth is there is no specific age when hormones must be stopped. That is a conversation between you and your doctor. I will tell you that my oldest patient who I've ever treated for hormones is a male patient who was 103 when he died. He came to see me for hormone support amongst many other things, and he was in his early 90s. And finding a doctor who was going to be open to practicing hormones for somebody at that age is hard to find. But I had the privilege and the honor of helping him throughout his journey. And that was one of multiple things that we were supporting. Yeah, so, he passed. Yeah, but, and what's interesting too is people have questions about what you're using and why and what preparation. So even with guys, you're thinking about testosterone not just being testosterone in the body. There's free testosterone that's bioavailable. There's testosterone that is inactivated. There's ways to look at that. There's testosterone that converts to estrogen. It's complicated, which is why it needs a thoughtful conversation with your doctor, and we shouldn't just be buying random things on the internet, because some people are doing that. So myth number 2, menopausal hormone therapy causes and significantly increases breast cancer. Truth, it's generally safe, and breast cancer risk is rare, and it can be mitigated with screening. This is a hard one, and I think it's hard for me because as a breast cancer survivor, I've always wondered what place hormones has for me. There are other studies that have been done over the course of the years, and this book is in the Love.Life library. It's called Estrogen Matters by Avram Blooming, and it looks like Carol Tavris. So they have put out a lot of information about how and we're talking about the breast cancer population in this particular article that he wrote. And this was also published in a journal, I think 3 years ago. I have it here in case anyone is interested. But hormone replacement therapy after breast cancer, it is time. You rarely see anybody having conversations about this, especially for people who have had cancer. But I'll tell you, I went to see my OBGYN just a couple of days ago. I'm 7 months postpartum. And interestingly enough, she said, "Did you know that you could be on vaginal estrogen? I wonder why your oncologist hasn't prescribed that." And I said, number one, of course, I did know that. And number 2, most oncologists will shut down the conversation when it comes to anybody post-cancer being put on any kind of hormone replacement therapy whatsoever. The truth is that when they did studies to look at replacement in patients who have had cancer, there were something like 25 studies over the last couple of decades that were done, starting in the 90s up until, I believe, 2010-ish. And during all of the assessments of looking at all those studies, only one of the studies showed an increased risk, but 24 of them did not show an increased risk. And then Dr. Avram, he kind of puts this and lays it out in his articles to show us no difference, reduced mortality, reduced recurrence, reduced cancer-related mortality. And there was only one study. But in the early 2000s, because of that one study, unfortunately, it was spun that all hormones are bad and nobody should be on them. And so for decades, so many women that could have had relief, remember that list of the 75% of women are going to experience it, so many women who could and want to use hormones as part of their toolbox were denied that. And so it's a really tough conversation to have now because I think so many people are waking up, they're getting curious, they're learning, they're coming to things like this where they're also getting a different kind of education, and we're realizing that that was a myth. So let me just put it back here again and remind ourselves that this is a myth, that it causes and significantly increases breast cancer. That is simply not true. The next one, Hormone replacement therapy causes cardiovascular disease. You remember that article I showed from the American Heart Association? He talks about how it's actually the opposite, that hormones do have a place and estrogen therapy does support cardiovascular health. This is another one that you'll often hear, and this is also simply not true. Here's another one about dementia. Bones, brain, and heart. Hormones to support bones, brain, and heart. And there's brain. It says here, menopausal hormone therapy causes dementia. It's the opposite. Estrogen has neuroprotective benefits, and hormone therapy may help reduce dementia risks. So it is not what people seem to think. The other thing that I remind myself of is that no matter who you are in this room, we all have estrogen flowing through our bodies. We all have progesterone flowing through. We all have testosterone. And for some of us that have I'm 7 months postpartum, all my hormone levels were up here to have my son Koa. So sometimes when people think about hormones as being dangerous, you have to remind yourself that all of our bodies have hormones, even if we've had a hysterectomy, even if you've had one, because the adrenal glands are still producing some of that testosterone and some of that estrogen as well. Myth number 5, hormone therapy causes weight gain. Opposite, true. May help mitigate weight gain and metabolic changes that happen with menopause. So in the Menopause 3.0 lecture, I talked about how the metabolism changes and things slow down as we go through perimenopause and menopause. And hormone replacement therapy can actually help that. So this is also a myth. What I'd say is that for women who have ever been put on hormone replacement therapy and they continue to gain weight, likely their body isn't metabolizing those hormones the way that it should. And so there are ways to look into that. There are tests that help us understand not just what the blood levels are, but also how your body is metabolizing it. So I like both. We use the serum testing as part of our 120 biomarkers comprehensive labs, and then we also look at the metabolism. So anybody that comes to see me who's on any kind of hormone replacement, we're looking at both. Because what the serum levels are is one thing, that's just in the blood, but how your body uses the hormones and how it metabolizes them, how it breaks them down is another thing. And so for a lot of patients that you see who are on hormone replacement therapy are continuing to gain weight, likely they're not metabolizing those hormones well. And that's where I think this one could have a little asterisk. So here's what we do at Love.Life. We support hormone health with so many different tools. We have nourishing meals that are curated without anti-inflammatory foods, without seed oils. We have this incredible fitness studio that also has incredible trainers that people work one-on-one with. I love our physical therapy personal trainer program that they call PT Squared. It's an opportunity for people to see a physical therapist and a trainer in one session. And you don't really see that in most places. So people get the best of both worlds there. We're continuing to build community. We have events like this so that we all can learn from each other, which is why after this talk, I love that opportunity for us to just, have questions and have conversation. The on-site labs and the diagnostics are done here. We do DEXAs on-site. Our patients are also drawing labs on-site as well. And then when you looked at that diagram that had serum and urine and cortisol and at-home tests, sometimes those play a role. And sometimes I'll send people home and I'll say, hey, there's a test kit that I want you to complete. So it'll give us more information and we can talk about those results. You see spa and recovery modalities, the state-of-the-art recovery modalities that we have that so many people love. And our members also have access to myself, Dr. Anna, and our expert care team with unlimited messaging, in addition to the visits, in addition to the acute care as well. So, final thoughts. Hormones have a place. They're not perfect. There is a science to how your body uses them. It is one tool out of so many tools that I showed you that are available to us. And we never start there. Most important. Because most people who think they want hormone replacement, I find out that their sleep sucks, they're super stressed, they might be on 15 different medications, half of which they don't know why, or even supplements of which they don't know why. Their metabolism is much slower, their gut microbiome is a wreck, and I wouldn't start with hormones, I would start with laying down a really strong foundation. And then we have thoughtful conversations about hormone replacement therapy when that happens. So that's typically how we approach it. Next, we're gonna have a conversation about breakthroughs in pain management. And I think pain, we know about it as a vital sign. It's not commonly thought of as one of the 4 vital signs, and in women we always think period cycles were also a vital sign, but pain is a vital sign. So I find it to be quite fascinating. That is going to be a thoughtful conversation around different ways that people are supporting pain management. We're going to talk about melatonin, vitamin D, and sleep. Interestingly enough, melatonin is not just created in the brain. It's created in the skin during the day. So whenever I say that, people are like, what? That's why it's so important for you to come to that one so you can learn about it. And then the last one, gut health, metabolism, and the microbiome. I'm bringing in a special friend for that. Her name is Dr. Tara Zinnemann. She is a neuroscientist. And we're going to talk about the gut-brain axis. And I think it's going to be fun for you to learn from somebody else and not just hear me talking. So we have a few exciting ones coming up. This is the 8-week series. Our experts and our team are also going to continue these thoughtful conversations and education around different topics. But that is all I have for you today. So we are going to turn off the video. I'm going to take a sip, and I'm going to move a chair so that we can just talk about hormone replacement therapy, and you all can ask questions. And if anybody asks personal questions, I will always reframe it so that I'm not giving you direct medical advice. Sound good?